countries. In March, we organized a webinar dedicated to tobacco and environment, focusing on harmful contribution of the tobacco and e-cigarettes to pollution and climate change. And today we're continuing the theme with a more targeted webinar on the topic of air pollution, in particular addressing the effects of the secondhand smoke. Before I would give floor to our first speaker, Elif Dagli, I would like to firstly introduce our speaker. Professor Elif Dagli, who is a pediatric pulmonologist who will represent the ERS, European Respiratory Society, as a member of the ERS Tobacco Control Committee, as well as from 2020, Professor is the Environment and Lung Diseases Working Group Executive Board Member at Turkish Thoracic Society. Elif is involved in tobacco control advocacy since 1985. Moreover, Elif is a winner of awards and of American Cancer Society as an outstanding leadership as in 2018. Professor will give us a presentation on the topic of health effects of secondhand smoke. Professor, the floor is yours.
Thank you very much for the invitation and the kind introduction. I'm going to talk about the health effects of passive smoking. The mainstream tobacco smoke is the smoke that is inhaled by a smoker and then exhaled into the environment. And the side stream smoke is the chemical mixture. This is only showing the chemical mixture that enters the air from the lit end of burning cigarettes and constitutes the bulk of the second-hand smoke. And the combination of these two smokes, with the burning and the smoke from the burning end of the cigarettes and the breathed out by the smoker, is jointly called secondhand smoke. And secondhand smoke contains more than 77,000 chemicals, and hundreds are toxic, and we know that 70 of them can cause cancer. Tobacco smoking is the most important resource of the indoor particulate matter 2.5. Indoor PM 2.5 are more critical, it has a more critical role than the outdoor one in the development of chronic lung diseases. Epidemiological studies showed the exposure of ETS, environmental tobacco smoke, plus PM 2.5 were both risk factors for chronic lung diseases, lung cancer, asthma, and COPD. Tobacco can also be deadly for non-smokers. Secondhand smoke exposure causes 1.2 million deaths annually. 65,000 children die each year due to illness related to secondhand smoke, and smoking while pregnant can lead to several lifelong health conditions for the babies. Heated tobacco products and electronic cigarettes have the same emissions, toxic emissions, and they can cause many different diseases. There is sufficient evidence to say in adults that secondhand smoke causes coronary heart disease, lung cancers, nasal irritation, stroke, and reproductive effects in women, such as low birth weight. If you look at the collective diseases caused by secondhand smoke in children and adults, you can see a number of diseases in this list, which is exactly the same for active smokers. Breathing secondhand smoke interferes with the normal functioning of the heart, blood, and vascular systems. Even brief exposure to secondhand smoke can damage the lining of blood vessels and cause your blood platelets to become stickier. People with heart disease are especially at higher risk. Secondhand smoke increases the risk of developing heart disease by 25 to 30%, cause coronary heart disease and stroke, increases the risk of stroke by 20 to 30%, causes deaths from stroke, causes premature deaths from heart disease. Secondhand smoke also causes lung cancer. Non-smokers exposed to secondhand smoke inhale the same cancer-causing substances and poisons like smokers. Secondhand smoke causes lung cancer in adults who have never smoked. increase the risk of developing lung cancer by 20 to 30% in non-smokers. Even brief exposure can damage the cells to set cancer process. Higher level of exposure means greater risk of developing lung cancer. It has been recently shown that passive smoking is associated with increased risk for breast cancer in women. European Respiratory Society has developed a tool, an educational tool on the health hazards of passive smoking, especially in children. And it is here shown that passive smoking in children causes asthma and wheeze, pneumonia, lower respiratory tract infection, and lung function impairments. Harms from tobacco begin before birth, as pregnant women who smoke give birth to infants at higher risk of congenital disorders, cancer, lung diseases, and sudden death, which is indicated in the recent ERS monograph shown here. In utero, secondhand exposure is a very important issue. Maternal tobacco and nicotine used during pregnancy adversely affects the health of the mother and the unborn child. But similar effects are also seen in mothers who are exposed to the tobacco smoke and not smoke themselves. Mother smoking changes the baby's epigenome, which these changes caused by developing developing fetus to have long-lasting consequences, and this can be debated as the violation of child's rights. Mothers who have smoked during pregnancy have high risk for obstetric complications. Chemicals of tobacco constituents reduce the placental blood flow and create hypoxic environment. Maternal smoking or passive exposure during pregnancy increases the risk of early birth and low birth in newborns. There is sufficient evidence to say that the secondhand smoking causes sudden infant death syndrome, asthma, wheeze, impaired lung functions, lower respiratory tract infections, respiratory symptoms, middle ear disease in children. Secondhand smoke causes many other problems in children. Children whose parents smoke, they have lungs that grow less, get sick more often, they get more ear infections, they get more bronchitis, pneumonia, wheezing, cough, and they also have severe frequent asthma attacks. Sudden infant death syndrome is a really critical issue. Smoking by women during pregnancy increases the risk of SIDS. Infants who are exposed to secondhand smoke after birth are at greater risk for SIDS. Chemicals in the secondhand smoke affect the brain of the babies and its regulation of infants' breathing, and the breathing suddenly stops. Infants who die from SIDS have higher concentration of nicotine in their lungs and higher levels of cotinine. It has also been shown that maternal passive smoking exposure results in a 1.5-fold increase in the risk of orofacial clefts. As you can see, the lip cleft here. It has also been shown that tobacco smoke induces several immunological changes in various organs and tissues in child before birth, during birth, and after birth. And this inflammation and immunological changes causes a lot of different diseases in several organs. The last issue is the third-hand smoke. Third-hand smoke is the contamination that persists after second-hand smoke has been emitted to the air, and it refers to tobacco-related gases and particles that become embedded in materials such as carpets, walls, furniture, blankets, and toys. Third-hand smoking is not a smoke, but it is a chemical adherence to the surfaces which can release back into the air and undergo chemical transformation and can be accumulated in different surfaces. Finally, I will talk about second-hand smoke index, which is the measurement of deaths That's really interesting because it is an index that measures the number of individuals who smoke associated with the death of one person. It basically means that to kill one person from secondhand smoke, how many people do you need to smoke? It has been shown in this study for very long years, different smoking rates and all that. They have actually found that you need 52 individuals to smoke 24 years to kill an individual with passive smoking in 2016. So it is really bad that people who smoke are not only responsible for themselves, but also responsible for others' deaths. And this is a legal perspective from a criminal attorney from my group. And he's basically saying that the science is well established about this. And it means that crime can be found under the perpetrator's indifference to the health of others. So we need to discuss this further. Is it only the responsibility of the governments to legislate, or can we have some individual responsibilities about this issue as well? Thank you very much.
Thank you very much, Professor, for your wonderful and informative presentation. I would like to ask our attendees if anybody has any immediate questions, unless we're going to ask them in the dedicated time for the Q&A in the end. Well, I think no. Then the second presentation will be given by Giuseppe Gorini and Giulia Carreras. They will represent the Institute for the Study and Prevention of Cancer. Giuseppe Gorini is a senior epidemiologist with a degree in medicine, specializing in public health and biostatistics. Dr. Gorini is a senior researcher in the convention between ISPO and ENSP. Giuseppe was a principal investigator in the 2010 CCM project, Future Scenarios of Smoking Prevalence and Smoking Attributable deaths in Italy, using simulation models of impact of tobacco control policies. On the other hand, we have Giulia Carreras, who is a statistician with a degree in mathematics and a PhD in statistics. Dr. Carreras is involved in project coordinated by Dr. Giuseppe. Together, they will give us a presentation on the topic of public health consequences and economic burden of tobacco, secondhand smoke, and e-cigarettes emissions. A small remark that the questions to the Dr. Giuseppe should be asked just after the presentation, because he has to leave us shortly after his presentation. So, Professor, the floor is yours.
Thank you very much, Fyodor, for your nice presentation. I'll share my screen. Okay. Here my presentation. Thank you to the ENSP for the invitation. I'll present with Giulia. Giulia is here, but I'll speak for both. And about the public health consequences and economic burden of tobacco SHS exposure above all, because we conducted the study, the TackSHS study, the tackles second-hand smoke exposure study that was finished 1 year ago, 2 years ago perhaps. And I'll present the final results regarding the burden of the second-hand smoke exposure in all the 27 European countries, because we considered also UK, because we began before the Brexit. Then I brief preface in order to understand what is the measure DALI, that means disability adjusted life years. You can see here that there is a lifespan in this graph from the birth to the death. You can see here the gray area is the healthy life in years, and then in the orange line here is disease or disability, years with disease and disability, and then there is the dotted line that means early death. So the years you lose if you die early due to, in this case, a second-hand smoke exposure. So we study this measure that DALIS, this acronym, that means the cumulative number of years of life due to ill health, disability, and death altogether. And the burden of disease attributable to second-hand smoke quantifies the number of DALIs that could be avoided by removing exposure to second-hand smoke. As Elif already said, we concentrated our attention to diseases causally linked to SHS exposure. In this slide, we conducted a systematic review. At the bottom of this presentation, you can find the references of our articles. But anyway, you will consider for children this outcome, these diseases: low birth weight, a low that is due to mothers smoking, low, and then low respiratory infections, otitis media, asthma, and sudden infant death syndromes as outcome we studied for children. Instead, for non-smoking adults, we considered in ischemic heart disease, chronic obstructive pulmonary diseases, the so-called COPD as an acronym, stroke, diabetes mellitus, asthma, lung cancer, and breast cancer in women that was added recently in the list of disease causally linked to SHS exposure for adults. And here, main results for children. You can see here the percentage in this graph with all the countries, European countries, the proportion of DAL is attributable to second-hand smoke exposure at home, because we consider above all the exposure at home, because after the development of smoking bans in Europe, in all Europe, the most important source of exposure to SHS remained home, and so, and above all for children. So we studied this proportion. You can see that, and every bar contains all these diseases. And you can see for all European Union here, we in 2017 we 335 deaths were attributable to second-hand smoke exposure in children, exposure at home, and we lost about 37,000 DALIs. And you can see here that the percentage was 0.7% of all DALIs lost in children this year. And there is a sort of a big difference between some countries. For instance, the Nordic countries here, Finland, Estonia, Sweden, but also Belgium and Netherlands, recorded an attributable of DALIs of 0.4%. Instead, in the eastern part of Europe, above all Bulgaria, Slovakia, Poland, and Romania, the percentage was more than 1.2%. And you can see here that the most part of this difference was due to the orange area, that means a low birth weight, but also for Romania, above all, a very high percentage in a lower respiratory infections, that for children is above all bronchiolitis. Then we can see here the ranking of the percentage. The lightest color are the countries where the proportion of DALIs attributable to second-hand smoke exposure at home was lower. For instance, Sweden, Finland, but also Italy, UK, France, Spain, Netherlands, Belgium. Instead, the eastern part, above all Bulgaria, Romania, Poland, and also Slovakia and Hungary, but also Austria, recorded the highest levels of attributable DALYs. In looking instead to adults, we considered as well exposure at home in 2017, and we did the same picture, the same graph. You can see that we lost about 24,000 deaths due to exposure to secondhand smoke at home in adults, no smoking adults in Europe. About 500,000 DALYs lost. The European Union altogether is about 0.4% of all DALYs lost in 2017 for adults. And the lowest level was recorded as in Nordic countries, less than 0.3%, but also not only Nordic countries such as Finland, Sweden, but also Germany, UK, France, Denmark, Netherlands. Instead, the highest levels of exposure and also of attributable death and DALYs were recorded in Poland, Croatia, Romania, and Bulgaria. And you can see here that the different colors are attributable to different diseases. In these countries, in the eastern countries, Poland or Bulgaria, the main, in the highest level was recorded for ischemic heart disease and stroke, but also for chronic COPD. And this, the level here was more than 7.7% of attributable deaths and DALY. This is the same map where the lightest color means, the lightest gray means lowest level. So you can see UK, Germany, France, and Belgium, Netherlands. Instead, the highest levels were recorded in Bulgaria and Romania, and in other Eastern European countries. Looking at the last part, the economic burden, we studied in collaboration with the professor Angel Lopez Nicolas of the University of Cartagena in Spain, the quality gains and the healthcare cost savings in the left part with the blue bars. You can see how many quality adjusted life years that is a similar measure of DALYs, but is adjusted not only for disease, but also for quality of life. If a smoke-free home scenario would be implemented, and we can see that, for instance, in Bulgaria, we would gain about 50,000 quali life years, and in Germany more than 1,050,000 quali. In England, Wales, Italy, and Sweden, and Spain around 100,000. The difference depends on the number of population considered, because Germany is the most populated country in Europe, so it's due to this. So what does it mean, a smoke-free home scenario? In a scenario where all the homes in Europe would develop a smoke-free home without smoking in the houses. Instead, in the right part where there are this orange bar, you can see the savings of healthcare costs in 5 years, from 2020 to 2024, in millions of euros. So you can see that we would save about 50 million euros in Bulgaria, about more than 200 million euros in Germany, and around 150 to 200 million euros in England, Italy, and Spain, if we would implement this smoke-free home scenario. Okay, and here I finished. These are the references of the articles regarding, above all, the second and smoke burden. So thank you very much. It's all.
Thank you very much, Dr. Gorini, for your incredible presentation. As I mentioned before, if any of the attendees have questions to Doctor, they should address them now because Doctor will leave us shortly.
There is a question. Is the difference between northern and eastern countries directly explained by the status national smoke-free regulations, or are there other factors? In the calculation, we considered the exposure. I think that it depends not only from smoke-free regulation, because also in eastern part of countries, eastern countries, there was the development of a smoke-free smoking ban. Even though they developed the smoking ban afterwards, not at the beginning, not earlier. So it depends on both, from the in some ways from a higher exposure at home, due above all to the fact that the exposure at home, it depends indirectly to the development of smoking ban, because we observed in Europe that when a smoking ban in public places, workplaces is developed, afterwards, in some years, also a voluntary smoke-free home are developing. So it's a sort of effect, indirect effect of the development of smoke-free ban. So what we saw that in Eastern country, the exposure to second-hand smoke at home was higher. So the attributable burden was higher as well. It depends on that the smoking ban were developed later. So in some ways, there is an effect indirectly due to the later development of smoke-free ban. I hope to be clear.
Thank you very much for your wonderful and extensive answer. Are there any more questions to Doctor? Okay, well, if there is no questions, I again thank you very much for your incredible presentation. And I would like to introduce you the speakers for the third presentation, who are Dr. Silvano Gallus and Alessandro Lugo, representing the Mario Negri Institute for Pharmacological Research. Dr. Silvano Gallus is the head of Laboratory of Lifestyle Epidemiology at Mario Negri Institute for Pharmacological Research. In almost 20 years of experience in the field of epidemiology and public health, he has gained wide knowledge and expertise in epidemiology, public health, biostatistics, and computation, collaborating in various national and international projects. Since 2001, he is responsible for the epidemiology of tobacco smoking in his institute, working mainly in the monitoring of smoking prevalence, its determinants, and strategies to control tobacco in Italy and Europe. He is an author of more than 250 papers published in the peer-reviewed journals. As well as we have Alessandro Lugo, who obtained the PhD in biomedical statistics in 2015 at the University of Milan. She's now a postdoc researcher at the Laboratory of Lifestyle Epidemiology at Mario Negri Institute. The main topics of her are the epidemiology of smoking and the monitoring of smoking habits in Italy and Europe. Together, they will discuss the attitudes of the European population to indoor and outdoor smoking bans.
Thank you, Fedor, and thank you for the invitation and for this introduction. So I will talk to you about the attitudes of the European population to indoor and outdoor smoking bans. Next slide, please. taking advantage of data from the Touch survey. This survey has been conducted within the Touch project, which was a project funded by the European Commission, aimed at understanding, investigating the role of secondhand smoke and secondhand aerosol of electronic cigarettes on the health, respiratory health of European population. Within this Touch survey, we conducted within this Touch project, we conducted a survey in 12 strategically selected European countries, including the most populated countries. And these 12 European countries represented around 80% of the whole EU population. We conducted the fieldwork in 2017, 2018 through a computer-assisted personal interview survey. And the number of participants was approximately 12,000. In each country, it was representative. The sample of around 1,000 was representative of the general population aged 15 years or more. Next slide. The questionnaire was focused on secondhand smoke and secondhand aerosol, but a specific section was devoted to the support of Europeans for smoke-free legislations in both indoor and outdoor settings. And now I will present to you the support of Europeans by country and overall for various indoor and outdoor settings. Next slide, please. And here we can see the support of Europeans for the smoking ban in restaurants and bars. So we can see that more than 75% of non-smokers and more than 60% of current smokers were favorable with a restriction in restaurants and bars, and the same was applied to discos and clubs. Next slide, please. Approximately the same proportions have been shown for workplaces and train stations. Still more than 75% of non-smokers and more than approximately 65% of current smokers were in favor of such bans in indoor places, in these indoor places. Next slide. Still a large proportion of Europeans, both non-smokers and current smokers, were in favor of the ban into private cars with minors, whereas this favor decreased to 60% among non-smokers and to less than 40% among current smokers for private cars without minors inside. The next slide, please. With reference to outdoor smoking bans, to an expansion of the smoking bans to selected outdoor places, we can see that approximately 55% of non-smokers and 1/3, but also 1/3 of current smokers were favorable to have this smoking ban in stadiums, in stadia, and at bus tram stops. Next slide. This proportion increased substantially when the settings were devoted to children, in particular in children's playground and in outdoor areas of schools. As we can see, the large majority of non-smokers, but also the large majority of current smokers were in favor of such restrictions. Next slide. These restrictions, the support decreased to approximately 50%, but still 30% of current smokers were in agreement to extend the smoking bans to beaches and parks. Next slide, please. In general, we observed that the countries with a higher tobacco control initiatives and with the low smoking prevalence had significantly higher support for these bans in outdoor places, and countries in Northern Europe and in countries with higher gross domestic product per capita, and therefore the wealthy countries had showed a higher support for smoke-free legislation in indoor places. Moreover, we observed that a lower secondhand smoke prevalence was significantly related with a higher support for smoke-free legislations in most of the countries. Next slide. In conclusion, our results show that the majority of adults in the European Union, including both non-smokers, but also a large proportion of smokers, are supportive of implementing smoke-free restrictions, both in indoor places, but also in selected outdoor places. We also observed that the support was very high in settings with children, and moreover, for most places, the support for smoke-free legislation was directly associated with the country's degree of adoption and implementation of tobacco control policies, and also per capita gross domestic product, whereas it was inversely associated with smoking prevalence and the prevalence of second-hand smoke exposure. Next slide. Thank you, therefore, for your attention. And if you have questions, myself or Alessandra could provide answers.
Doctor, thank you for your brilliant presentation. And again, yes, if anybody has any immediate questions, now is the best time to ask them. However, if not, I would like to present our fourth speaker, and the fourth topic will be presented by Dr. Krzysztof Przewozniak, who will represent the Maria Sklodowska-Curie National Research Institute of Oncology, as well as he's one of the ENSP board members. Dr. Krzysztof has more than 30 years of experience in the field of public health, health promotion, cancer, and tobacco control. Doctor advised to the Polish government during the Polish presidency at the European Council, as well as he has been working or collaborating with the World Health Organization, International Union Against Cancer, and many other organizations. For his scientific, social, and public health work, he has received awards from the President of the Republic of Poland and many others. Doctor will discuss the effectiveness of the smoke-free policies in Europe. Doctor, the floor is yours.
Good afternoon, everyone. Do you hear me?
Yes, we can hear you.
Great. I'm sorry, I've been a little bit late because I had technical problems in connecting with you. So first of all, I would like to send warm greetings to all my colleagues and friends, and thank you so much for interesting presentation. Unfortunately, I didn't hear all from the presentation made by Professor Dagli, but the rest I heard a lot. So let me share the screen. Do you see the presentation now?
Yes, it's perfect.
Okay. Okay, so my presentation is on smoke-free policies, in fact, on the effectiveness of such a policies, mostly in the European Union. But finally, I decided to take a look at the current picture and the latest changes, especially in exposure to SHS and HTP use. So partly my presentation is connected to the TackSHS study that has been conducted by Silvano and Alexandra. For sure, there is a need for enforcement of comprehensive smoke-free policies, and it results from, let's say, fourth reason. The reason number one is health effects of SHS exposure. The second one is social and economic benefits of such a policy. That policy is also scientifically proved in terms of effectiveness, and we have the article number 8 that recommends such a policy. The effectiveness of smoke-free policy can be analyzed in different terms, in terms of reduction of SHS exposure among tobacco users and non-smokers, its impact on reducing SHS exposure at home and private cars and other non-public venues, in changes in attitudes toward tobacco control, tobacco use and cessation rates, a reduction in tobacco-related health burden, socio-economic benefits for households, state, employers and employees, and what was done nicely by Silvano and Alexandra, support for and compliance with such a policy. However, the studies show that the reduction in SHS exposure is direct and relatively persistent effect of the enforcement of comprehensive or smoke-free policies. So I, first of all, will be focusing on exposure to evaluate from smoke-free policy, both in terms of exposure to SHS, but also exposure to ENSP and HTP. As I said, mostly in the European Union. The analysis is based on 3 Eurobarometers results. The last one that has been conducted lastly, in fact, in summer 2020, the previous one from 2017, and the last one that was conducted in 2014 in order to compare the results, because the same questions, you have these questions here, have been asked in all this Eurobarometers survey. The most important question looks like that. The last time you visited the following places in the last 6 months, which is very important because this is, let's say, retrospective a little bit question, were people smoking tobacco products in a drinking establishment, in eating establishment, then almost the same question on exposure at outdoor terrace in drinking or eating establishment, at outdoor events, and in other outdoor spaces. As regards exposure to ENSP and HTPs, there was a question on exposure to these products at drinking establishment and eating establishment, but also in another public space where people normally don't smoke, like shopping malls, airport, and concert halls. What I additionally did was so-called analysis of ranking points. So each country is, in my analysis, ranked in relation to its exposure to SHS and ENSP use in specific public venue. Country with the highest exposure has the lowest rank, number 1. Country with the lowest exposure has the highest rank, 28, because the number of countries in the European Union. If exposure is at the same level in few countries, then all these countries have the same rank. For some categories, for instance, for SHS exposure in all venues, ranking points are summarized. Again, country with the highest combined exposure has the least points, and the countries with the lowest combined exposure has the most ranking points. Let me show you the results, which are quite interesting, by the way. I'll be a little bit commenting in a minute, but as you can see, if we taking a look at the exposure to SHS in drinking establishments, there is a big difference between such a countries as Croatia or Cyprus or Slovakia. On the one side, to Hungary or Sweden or Austria. Not only Ireland, not only Sweden, not only UK, but also lastly also Austria. If you take a look at, I'm sorry, if you take a look at eating establishments, the picture is mostly the same, or at least similar. So the countries with the lowest exposure are Hungary, Slovenia, Sweden, Denmark, Malta, but also Germany, that results from that study, which is a little bit surprising, or Austria. I'll be commenting that, as I said before, but the highest exposure, 10 times higher, is in Cyprus, or 5 times higher is in Slovakia or Bulgaria. As regards outdoor terraces, the difference is even much bigger. Very low exposure in such countries as Sweden, Hungary, or Slovenia, again Austria, and very big in Croatia or Cyprus. As regards outdoor events, this is really, let's say, the challenge that we have, especially now, especially at the time of COVID, because people just waking up, you know, to take part in such events. You can see that the level of exposure is much higher than the exposure in other public places, even in the countries where the exposure is the highest one, like Hungary or Sweden. The same is with the exposure in children outdoor spaces, mostly again Hungary, Sweden, Finland, Portugal, and Lithuania. These are the countries with the lowest exposure, and Cyprus, Bulgaria, Croatia, and which is surprising because Slovenia has a very good public health, Slovenia or France. Going to the issue of the exposure to ENS and HTP, you can see that the exposure nowadays is quite high. So in most of countries, the exposure reach at least 20, 30, or even 60% for such countries as Croatia and Cyprus. They are nowadays leading in exposure to both SHS and ENS and HTP. On the other side, Hungary, Austria, again, big surprise, Germany, Sweden, and Denmark have the lowest exposure to ENS and HTP. The same is with the bigger exposure is observed in Ireland and UK, but it can result from a little different approach to these products. So the same is with the difference in percent points in exposure to tobacco smoke in eating establishments. So you can see more and less those countries that have been pioneers in enforcing comprehensive tobacco smoke-free policies in the beginning of the new millennium, like Luxembourg, Ireland, UK, Sweden, Finland, and also Italy. Nowadays, they have, if we compare data from 2020 with data from 2014, higher exposure. So there is something alarming that we have more specifically in details analyze. The better situation, as I said, is in those countries that enforce a comprehensive policy just in last years. And if you take a look at the ranking points, you can see that Hungary and Sweden and Lithuania, these are, and also Austria, nowadays they are those countries in which the situation is the best, in which the exposure, SHS exposure in all venues, analyzed venues, but also exposure to ENSP and HTP, and combined exposure both to SHS and HTP is at the lowest level. Of course, we have to take into account some study limitations. So on the one side, this is, as usually with Eurobarometer, relatively small survey sample per country that is not reaching 1,000 respondents per country. But also the question, as I said, has a retrospective character. So we are asking about past 6 months. So people probably don't really know what is the detailed exposure. Another big challenge with this analysis, these studies, especially the last one, Eurobarometer, is potential country-specific impact of COVID and related hygienic restriction, because at the time people have protective behaviors, there are lockdowns in many countries, or at least limited access to public venues. So we have to take very carefully into account the results from the last Eurobarometer survey. However, the survey was conducted in the summer, so at least there is no seasonal effect. Differences in country-specific timing for enforcement of comprehensive smoke-free policy is also another important limitation. So for Ireland, that was long time ago, 2004. And lastly, in Austria. So maybe people much better remember what is going up, what is the hot issue, let's say, in such a country as Austria is. Results refer to only adult exposure, not to the youth exposure to SHS, and the analysis also doesn't take into account the comprehensiveness of smoke-free policies and compliance and support, but it was analyzed by Silvano. And last but not least, it seems that current picture and exposure to SHS and HTP has a little bit changed in the last years, so we have to more detailedly analyze that. It has, first of all, happened in relation to enforcement of strong smoke-free policies in such countries as Hungary, Austria, Greece, and Lithuania in last years. As other studies shows, it can be also influenced by higher public compliance. In other countries, it can be also associated with enforcement of partial or even complete bans of ENSP or HTP use in public places. However, the picture of the exposure can be substantially changed by country-specific hygienic restriction during the COVID. Nevertheless, the alarming phenomenon seems to be substantially increased in exposure to SHS and HTP, especially in eating and drinking places in countries that have been pioneers in enforcement of comprehensive smoke-free policies many years ago. So there is something what have to be analyzed in details. There is something which is more obviously that results from my analysis. I'm sorry once again for technical problems.
Thank you very much for your magnificent presentation. Despite those technical issues you've encountered, I think that this was a pretty wonderful presentation. And now, last but not the least, we will hear from the Panagiotis Chaslaridis, the policy advisor at EFA, the European Federation of Allergy and Airways Diseases Patients Associations, which is a partner and a member of ENSP. Panagiotis has an educational background in the field of European affairs and EU public policy, including 2 master's degrees in Greece and Belgium. He contributes to the EFA since 2018 to develop advocacy and communications initiatives vis-a-vis the institutions and other stakeholders in the context of specific policy dossiers. Panagiotis will give us a presentation on the topic of patients' perspective, engaging policymakers and advocating for smoke-free environments. Panagiotis, the floor is yours.
Hello, good afternoon as well. Let me just quickly share my screen in presentation mode. Thanks a lot, Fedor, for this invitation, for the organization of this webinar, and for the kind introduction. I'm glad to be here today to provide the perspective of patients in the discussions on tobacco, past and ongoing. Well, a few words about IFA first. IFA is the voice of over 200 million people in Europe living with allergy, asthma, and COPD, chronic obstructive pulmonary disease, representing 43 national organizations from 26 European countries, including non-EU countries such as Norway, Switzerland, Turkey, and the UK. This said, our main focus is EU policy and how smoke-free legislation evolves at the EU level. But we also engage at the WHO level on matters related, for example, to the implementation of the FCTC and the commercialization of tobacco. Internally at IFA, we organize our advocacy along 3 main work streams: inform, prevent, and care. Advocacy on tobacco falls naturally under our broader work on prevention, of course, but it's also linked to our work on inform, to the extent that we strive to raise awareness, among others, on the effects of tobacco on health to the wider public. As the previous speakers have very well demonstrated so far, smoking and exposure to tobacco smoke is extremely harmful for human health. Our patients in particular, for example, people living with a chronic respiratory condition, find themselves in a much more vulnerable position, already having to deal with a compromised respiratory health in their daily lives. Well, just to mention some of the proven effects of exposure to tobacco or to smoking tobacco, as the whole range is quite far-reaching. For example, tobacco smoke is a primary cause of COPD, a preventable but progressive chronic disease, expected to become the 3rd leading cause of death by 2030 at the global level. And at the same time, between 80 and 90% of COPD deaths are due to tobacco smoking, a quite high rate. Secondly, smoking with asthma is associated with a higher degree of asthma severity, worsening of asthma symptoms, increased hospitalizations, and accelerated decline in lung function. And maybe to note that parental smoking during pregnancy is also widespread, being harmful for the child. Smoking during pregnancy is associated with low birth weight, fetal deaths, and preterm delivery with reduced lung function. Similarly, there are several risks associated to our exposure to secondhand smoke, as it has been found, as the previous speakers have outlined very well. there is an increased risk of lung disease, but also an increased risk of baby sensitivities, increased baby sensitivities to allergens. So the level of harmful effects from tobacco explains why our patient community have long been passionate and persistent in their efforts to fight the tobacco epidemic and advocate for stricter control in the EU. And I will maybe state a few details in the next minutes. Perhaps it would be interesting then to refer to some of IFA's activities in recent years in the area of tobacco control. Important to note here that at IFA we consider tobacco as naturally linked with the quality of air, and this applies both in indoor and outdoor environments, as it is very, very eloquent. In advancing our cause, we work through several channels, including the formal procedure of consultations that are organized by the European Union, the collaboration with like-minded actors, but also IFA-led projects. Now, in the past, we have already fully been in line with ENSP calling for the elimination of tobacco use in Europe, the expansion of smoke-free environments, but also the strengthening of the human rights perspective of tobacco. One such example has been our joint work back in 2014 on a set of recommendations for the implementation of Article 20 on e-cigarettes at the national level, where we called member states to implement stricter policies on electronic cigarettes, such as a ban on the use of e-cigarettes in all public places where smoking is not allowed, and a strict regulation on flavors to limit vaping among children and young people. IFA has also contributed to the 5th edition of the Tobacco Atlas back in 2015, highlighting the impact of tobacco smoke, for example, as the primary cause of COPD in developed countries. More recently, the IFA Access Report of 2019, which was conducted among asthma and COPD, is a survey conducted among asthma and COPD patients in 7 European countries, and that showed that 9 out of 10 asthma and COPD patients consider indoor smoke to be the largest trigger of their symptoms, and therefore they applaud the trend, the wider trend towards eliminating indoor smoking, but also the promotion of smoke-free environments as per the Article 8 of the FCTC. However, one out of 3 think that exposure to secondhand smoke is still too high, and that the authorities should do more to protect them. Now, IFA has also been active in the context of related policy activities and procedures such as the European Beating Cancer Plan, where we emphasized the several shared risk factors between cancer on the one side and allergy, asthma and COPD on the other side. These include, of course, tobacco use and the exposure to tobacco smoke. In this context, we called the Commission to update the tobacco products legislation to cover once and for all current and novel tobacco-based or smoking products as items posing a danger to human health, but also to harmonize the taxation of tobacco products across Europe, and continue enabling member states sharing of best practices and actions to enforce the WHO FCTC. Of course, in light of the final plan of the beating cancer, of Europe's beating cancer plan that was adopted earlier this year, and putting forward several actions on tobacco, including the review of the TBD and the creation of a smoke-free generation, we are closely monitoring the developments, expecting some very, very active months and years ahead. Then we also engage with on the consultation of the EU Renovation Wave and the revision of the European of the Energy Performance of Buildings Directive, which is still ongoing. Approaching it from the perspective of indoor air quality. Of course, indoor pollutants can be many, but certainly tobacco smoke is among the most dangerous ones, especially if we talk about vulnerable groups such as children or chronic patients. We also participated in the recent consultation of the Scientific Committee on Health, Environmental and Emerging Risks of Opinion on e-cigarettes, which was meant to feed into the implementation report of the European Commission that has just been published a few weeks ago. We took this opportunity to highlight the evidence linking the use of electronic cigarettes with adverse effects on respiratory health. For example, the greater prevalence of inflammation among asthma patients, especially in short-term vapor inhalation. The fact that electronic cigarettes can trigger processes that drive the development of the disease of COPD patients, and the fact that electronic cigarettes use can increase the risk for allergic rhinitis and asthma. And moreover, we called for the regulation of electronic cigarettes in the same or even stricter way as tobacco products, and that includes the prohibition of industry practices such as flavorings and device coloring. And actually, we consider it an increasingly concerning issue given the rise of market share for novel products such as electronic cigarettes and heated tobacco products, as documented in recent Eurobarometer surveys. Last but not least, we also raised the cause of healthy smoke-free living and working environments in the context of the ongoing revision of the air quality directives, also ongoing, where we call for a comprehensive framework strategy on air quality, taking into account both indoor and outdoor environments. And of course, our arguments on tobacco are fully integrated in on this occasion too. This is my last slide. This is a project that I thought it would be very relevant to mention, the European Lung Health Group, which is an initiative that was launched last spring, bringing together healthcare professionals, including the European Respiratory Society and respiratory patient groups from several respiratory disease areas such as lung cancer, pulmonary hypertension, tuberculosis, cystic fibrosis, and idiopathic pulmonary fibrosis. One of the main outcomes so far has been the Breathe Vision 2030, which was published last January, featuring several tobacco-related targets, for example, the tightening of EU tobacco legislation, the implementation of the Framework Convention on Tobacco Control in all EU member states, including better regulation to protect against secondhand smoke exposure, and the alignment of policies on the commercialization, taxation, and norms between tobacco and newer novel smoking products. And therefore, we were happy to see these intentions, at least, in the recent Beating Cancer Plan that was adopted by the Commission. We also discussed aspects of awareness, such as the stigma around smoking, and especially the need for the stigma to be replaced with an understanding of harm prevention, early smoking cessation, and stricter policies to reduce the commercialization of these products. Finally, IF and the European Lung Health Group welcome organizations endorsing its Breathe Vision 2030 with 48 endorsers so far. Please don't hesitate to learn more about the vision itself, about its priority areas, but also how to endorse in the website www.breathevision.eu. Yeah, I will leave it here for now, but happy to take any questions as they can. Thanks a lot.
Well, thank you for your excellent presentation. that links our topic to the advocacy and to the and it shows how it's possible to bring this matter to the political agenda. So here I would like to say that despite the little technical difficulties that we have encountered today, I think our speakers gave us a very comprehensive overview of the issues around the secondhand smoke exposure. So now I would like to involve the audience and check if there are any questions or comments to address the speakers. Please either use the raise the hand option and ask the question personally, or you can type your question in the chat and we will address it to our speakers. We already had one question before. I think it was addressed to Krzysztof regarding the hookahs. Exactly. What do you think about hookah tobacco and shisha tobacco, especially in bars? It is used by many young people, but it's not accepted as a real smoking. I mean, this question can be answered by any of our speakers. However,
could I answer that?
For sure.
Because it is a very, very big problem in our country, in Turkey. And it should not be allowed because the emissions coming out from hookah are much more than regular cigarettes, and WHO has a position paper about that, showing that one session of water pipe smoking is equal to at least 100 cigarette smoking in volume. And also there's a huge secondhand smoke coming out of it. Plus, there are so many other health effects, like inhaling from the same flask. Even if you change the mouthpiece, you cannot sterilize the whole equipment. So in pandemic, it's really, really dangerous to use the same equipment without sterilizing the whole flask and the whole system. So we know that it is disseminating tuberculosis, hepatitis C, and it probably will spread coronavirus as well if it's used in pandemic. So it should be completely banned during pandemic, and it should be banned inside. And there are many cafes and restaurants of now serving hookahs. It is not like a specially designated hookah bars anymore. You can go to a restaurant and they can offer you after meal a hookah, which should be banned. I think we need to work on this collectively because it is becoming a bigger and bigger issue. And they also add some flavors and food additives into that, like you can have a watermelon hookah or you can have hookah, which is very dangerous for lungs because lungs cannot process food products. And all these aromas and additives in that are causing a lot of lung diseases, especially interstitial lung diseases and all that. So I think if you ever want to organize another webinar, please organize one on hookah, and then we can have more discussions. I don't want to take more of your time, but the short answer to this question would be, don't ever let anybody use hookah indoors, and all the legislations should cover hookah. And let me tell you, it has nothing to do with tradition, nothing to do with Ottoman tradition, nothing religious. It is not historical traditions. It's a completely new gadget. It wasn't there before 1990s because it is completely different with aroma additions and all these flavor additions. The normal hookah wasn't like that. And we have to fight over it. My quick answer is never allow anybody to use hookah indoors.
Thank you very much. I think we all fully agree that there is not that big of a difference between hookah use and tobacco use. The next question is, I honestly do not know to whom it should be addressed, but in the countries where smoking ban in public places is mostly implemented, what should be the next priority? Smoking in private cars, homes?
I can try to answer this question. I'm Silvano. And well, I would not prioritize private venues, although in cars the concentrations of pollutants when someone is smoking in cars are huge, and therefore, at least for in presence of minors, the smoking should be banned in cars. However, I would suggest to start from an extension of the smoking ban to selected outdoor places. In Milan, since Milan is one of the main municipalities in Italy, since January, mid-January, it is forbidden to smoke in stadia or in parks, also at bus and tram stops. And I believe that we are today ready, at least in Italy, to extend the smoking ban to these selected settings. This is extremely important also for in the environment, and therefore the mayor of Milan found a way also to obtain this decree, also pushing on the environmental reason, let's say, for this ban.
Thank you very much. Are there any more questions? Any live questions?
I can maybe reply to the previous question of Paulina, just very quickly. I do really think that after ambient air pollution, indoor air pollution should start coming to the fore. It has been quite neglected in the past, at least at the EU level, the discussion on indoor air quality. And what we have been calling consistently in the past, especially in the context of the Buildings Directive, for example, buildings legislation, is this mandatory certificate for indoor air quality that should be established for all new and renovated buildings. That could mean a measurement, a framework of measurement, indoor air pollutants, including tobacco, among others, but also mold, dust, and other pollutants that can have a harmful effect on the health of people with already existing conditions, but also trigger new conditions to healthy people. European Parliament back in 2019, but unfortunately we have not seen it advance in more recent years.
Let me make a few comments, just continuing what my colleague said just now. This is a very important issue. Do you hear me?
Yes.
Yeah. Still, there is a lot of to do, even in those countries with the quite strong or even the strongest and comprehensive smoke-free policies in Europe. As I told you in my presentation, there is something, wrong what is going on, even in those countries in which such a policy is at comprehensive level. This is the first. So we have more and more people exposed to SHS, you know, in bars, nightclubs. There is some, you know, how to say, islands that we have to go in, you know, and make a ban there. The very hot issue are nightclubs. This is very difficult, especially now at the COVID pandemic, you know, because nightclubs looks nowadays as islands of non-public health, let's say, venues at all. So this is the first. And the second very important issue is to do really step forward in collaborating with employers. In fact, the level of exposure to SHS in workplaces is at much higher level even than in restaurants or in bars. And there is a lot of to do with profits for both sides, you know, in such a collaboration. I guess European Union can help us a lot in communicating and engaging us and big employers in such a policy at both regional and country level.
Thank you very much. Are there any more additions on that topic? Are there any brand new questions? The last chance to have your question. And okay, well, then I would like to thank everyone who attended and participated in today's webinar. I think the speakers of today clearly demonstrated the dangers of tobacco, air pollution on individual health and public health overall. Furthermore, there is a clear support from the European population and proof of effectiveness of comprehensive smoke-free policies. We hope that this fruitful discussion will bring more attention to the negative effects that smoking has on our air, and how important it is to extend the smoking bans and protect the smoke-free legislation from any relaxation, and aim for 100% smoke-free environments. And hopefully we will see some advancements in tobacco laws completely prohibiting the use of both traditional cigarettes and novel products in public spaces. I would like to again thank everybody and wish you a happy World No Tobacco Day.